Welcome to this comprehensive Viva-related review of the humerus. We will dive deep into every anatomical detail and clinical correlation you need for your exams. First, let's determine the side. The upper end is rounded and forms the head, while the lower end is characteristically flattened from before backward. The head is directed medially and backward. Crucially, the lesser tubercle projects from the front of the upper end. On the anterior aspect of the upper end, you'll find the intertubercular sulcus, also known as the bicipital groove. This is a vital landmark. In the anatomical position, the head is directed medially, upwards, and backward. Position the bone correctly to see these relationships. The medial epicondyle is also directed medially and slightly backward, serving as a reliable guide for correct orientation. What's inside the groove? First, the tendon of the long head of the biceps brachii, enclosed in its synovial sheath. The third content is the ascending branch of the anterior circumflex humeral artery, supplying the shoulder joint. Remember, the lady between two majors. Teres major inserts into the medial lip, while latissimus dorsi inserts into the floor. Pectoralis major inserts on the lateral lip via a bilaminar tendon, with the two laminae continuous with each other inferiorly. The greater tubercle has three impressions: supraspinatus at the top, infraspinatus in the middle, and teres minor at the bottom. Don't forget the lesser tubercle. It provides the insertion point for the subscapularis muscle. The anatomical neck surrounds the head. The surgical neck lies at the upper shaft junction and is a very common site for fractures. At the surgical neck, the axillary nerve and circumflex humeral vessels are at high risk during fractures. These are common exam questions. On the shaft, the radial groove contains the radial nerve and the profunda brachii vessels. Damage here leads to wrist drop. The medial supracondylar ridge gives origin to the pronator teres from its lower end. Moving to the lateral side, the lateral ridge gives origin to the brachioradialis on the upper 2/3 and the extensor carpi radialis longus on the lower 1/3. The lateral epicondyle is the common extensor origin for several muscles, including extensor digitorum and extensor carpi ulnaris. Anconeus and supinator also arise nearby. Humeral torsion is the angle formed by the superimposition of the long axes of the upper and lower articular surfaces, typically around 164 degrees. Anteriorly, the radial and coronoid fossae accommodate the radius and ulna during elbow flexion. Let's look at the back. Posteriorly, the large olecranon fossa accommodates the olecranon process when the elbow is fully extended. Did you know? Fractures at the junction of the upper and middle thirds often lead to delayed union due to poor blood supply at that site. In supracondylar fractures, the median nerve is the structure most commonly involved. Always check for nerve integrity in clinical exams. Finally, ossification. Capitulum appears at 1 year, followed by the medial epicondyle, trochlea, and lateral epicondyle. Fusion occurs between 15 and 20 years. That's a complete review of the humerus. Review these points often, and you'll be well prepared for your Viva. Good luck!